Welcome to the deep dive. When we think about the incredible complexity of the human body, the kidneys are often unsung heroes, silently vital.
Absolutely.
But when something goes awry in childhood, the impact can profoundly alter a child's entire life trajectory.
It really can.
So today, we're embarking on a deep dive into alterations of renal and urinary tract function in children, a crucial chapter, really, that illuminates the unique challenges of pediatric kidney health. Our mission is to guide you through the major concepts, mechanisms, and clinical examples from this textbook material. We want to transform dense information into clear, accessible insights.
Right.
No visuals needed. We'll paint the picture with words.
And what's truly striking here is how different kidney and urinary tract disorders are for children compared to adults.
How so?
Well, a developing body means that many issues, especially in newborns, stem from congenital malformations. The way these systems mature or don't mature profoundly influences not just the types of diseases we see, but also how they present.
Okay.
It raises a critical question. How do these unique developmental stages really shape a child's renal health?
Let's start right at the beginning then. Structural abnormalities. We're talking about congenital abnormalities of the kidney and urinary tract, or cut.
Cut, right.
And these aren't just minor issues, they're a huge deal, accounting for a staggering 40% to 50% of renal failure cases in children in developed countries.
That's huge. Just staggering.
It really highlights why understanding these blueprint gone awry moments is so critical.
Absolutely. And CAC represents a spectrum. Sometimes it's about the kidney's position, like an ectopic kidney,
Okay.
where it's simply in the wrong place, perhaps down the pelvis, but often functions perfectly normally.
So location, but not function necessarily.
Exactly. Other times it's a fusion, like a horseshoe kidney, where the kidneys literally connect at the bottom, sort of U-shaped.
Right.
While many people live symptom-free with that, it can unexpectedly increase risks for infections or stones obstructions later on.
So those are location or shape issues. What about when the kidney itself doesn't, form correctly?
Yeah, that's what we see conditions like renal aplasia, where a kidney is simply absent because the early developmental signals just failed.
Completely missing.
Completely missing. Then there's a hypoplastic kidney. It's fully formed but unusually small with fewer filtering units, the nephrons.
Okay.
When both kidneys are hypoplastic, it's actually a significant cause of chronic renal failure in kids. Imagine trying to run a marathon with a smaller, less efficient engine, essentially.
Right. That makes sense.
And then there's renal dysplasia. That's different again. The kidney tissue itself develops abnormally. It might contain primitive structures, cysts, even cartilage.
Wow.
This often happens because of a blockage in the urinary tract before birth. That essentially throws a wrench into the kidney's proper growth plan.
So that's a stark difference. One is small but sort of organized. The other is just miswired, kind of.
Exactly. Miswired is a good way to put it.
And speaking of miswiring, what about polycystic kidney disease, PKD? That's an inherited condition, isn't it?
Yes, BKD affects about 1 in 1,000 live births. It's driven by gene mutations that cause countless fluid-filled cysts to grow, gradually interfering with the kidney's ability to filter blood.
And there are different types.
There are. Autosomal dominant PKD, ADPKD, often appears later in childhood or adulthood. And the cysts aren't just limited to the kidneys. They can show up in the liver, pancreas, even the ovaries.
How interesting.
This form also brings risks of hypertension and aneurysms, even heart valve defects.
Okay.
On the other hand, autosomal recessive PKD, ARPKD, is often suspected even before birth. It's generally much more severe.
More severe how?
Characterized by specific cysts in the collecting ducts and serious liver disease. Kids with ARPKD frequently need dialysis or a transplant during childhood or adolescence.
That's a tough road. So we're talking about conditions ranging from missing organs to malformed ones or kidneys riddled with cysts. What about the complete absence of a kidney?
That's renal agenesis. If it's unilateral, just one kidney missing, it happens in about 1 in 1,000 births. A bit more common in males.
And the other kidney compensates?
It usually does. The single healthy kidney often compensates by growing larger, almost doubling in size sometimes. But there's still a higher risk long-term.
Risks like what?
Things like protein in the urine, high blood pressure, and eventually chronic kidney disease over time. And they often have other anomalies outside the kidneys too.
Okay. And bilateral. Both missing.
The truly tragic scenario is bilateral renal agenesis, where both kidneys are absent. This is incredibly rare and sadly incompatible with life after birth.
Why is that?
Because the baby produces no urine in the womb, There's very little amniotic fluid, oligohydramnios, it's called. This leads to what's known as Potter syndrome.
Potter syndrome.
Yeah, a distinctive set of facial features. Wide-set eyes, sort of parrot beak nose, low-set ears, receding chin, all resulting from the compression in the womb due to the lack of fluid.
That sounds very difficult.
It is. These infants often don't survive long, usually less than 24 hours, mainly due to severely underdeveloped lungs. Fortunately, prenatal ultrasound can often detect this early.
That's a powerful and heartbreaking image. What if the kidney itself is okay, but the plumbing leading out of it is blocked?
Right, good question. That brings us to ureteropelvic junction, or UPJ, obstruction.
PJ.
Yeah, it's the blockage right where the kidney's collecting funnel, the renal pelvis, meets the ureter, the tube draining urine to the bladder. It's actually the most common cause of hydronephrosis in newborns.
Hydronephrosis, that's the swelling.
That's when the kidney swells up with backed up urine. Exactly.
Yeah.
Most often, it's due to a developmental defect in the muscle or the lining of that junction area.
That needs to be caught.
Definitely. It can lead to damage if it's not addressed. Similarly, other blockages can occur further down, like a ureterosu,
Ureteropelvic.
like a ballooning of the ureter right as it enters the bladder, kind of trapping urine behind it, often seen when there's a duplicated ureter.
Okay, so we've discussed these internal structural issues. Now let's maybe zoom out to structures we might not immediately connect to the kidneys, but are part of the broader urinary system and equally critical. For instance, hypospadias.
Ah, yes, hypospadias. It's a common congenital condition in boys where the urethral opening isn't at the tip of the penis.
Where is it then?
Instead, it's located somewhere along the underside, the ventral side. Imagine the urethral meatus appearing anywhere from just below the tip, down the shaft, or even way back in the perineum.
Wow, quite a range.
It is. And it can also come with other issues like chordee, that's where the penis bows downward, or penile torsion, a twisting of the shaft.
And there's surgery for this.
Yes. The goal of surgery, usually done when the child is about 6 to 12 months old, is not just cosmetic. It's really to ensure a straight penis for future function and proper urination. Minimal procedures, cosmetically acceptable result.
That makes a lot of sense, focusing on function and well-being. And then there are more severe fusion defects, right? Like epispadias and exstrophy of the bladder.
Right. These are really varying degrees of the same profound developmental defect, where the front wall of the urinary tract and the abdomen simply don't fuse completely during development.
Okay, so epispadias first.
Epispadias means the urethra opens on the dorsal or upper surface of the penis in boys, or there's a cleft in girls. This often leads to urinary incontinence because the bladder neck might not close properly.
And exstrophy is even more severe.
Much more. Exstrophy of the bladder is far more extensive. The bladder actually forms outside the body, herniating through an opening in the abdominal wall. It appears bright red and exposed.
That sounds incredibly severe and urgent.
It is extremely urgent. The pubic bones are often unjoined, which causes a distinct waddling gait later on. There's constant urine seepage, leading to skin irritation, excoriation, and pain.
And the risk?
Critically, the exposed bladder tissue is highly susceptible to cancerous changes, sometimes as early as 1 year after birth. So surgical closure is urgent, ideally within 72 hours of birth or through staged procedures in the first year. The objectives are clear. Preserve kidney function, achieve urinary control if possible, prevent infection, and improve sexual function later in life.
Wow, the speed and precision of intervention are just paramount there. And finally, what about a blockage closer to the bladder itself, like at the outlet?
Yeah, that would be bladder outlet obstruction, like congenital urethral valves in boys. These are thin membranes in the posterior urethra that can block, sometimes completely occlude, urine outflow.
Like a dam.
Pretty much. Imagine trying to drain a sink with a clogged pipe. The pressure builds up, damaging everything upstream the bladder, the ureters, the kidneys. Severe obstruction can actually impair kidney development even before birth.
So it needs quick treatment.
Absolutely. It can rapidly lead to renal failure if not resected promptly.
Okay. So we've explored the foundational structural problems. Now let's pivot a bit. What happens when the kidney's intricate filters, the glomeruli, come under attack, often from the immune system?
That's a crucial shift, because many pediatric kidney issues aren't structural at all, but rather acquired immune-mediated attacks on those tiny filters. Glomerulonephritis is the broad term for inflammation of these glomeruli.
And that's serious.
It can be very serious.
Yeah.
It's a major cause of chronic and end-stage renal disease in children.
One of the most common forms you mentioned earlier, maybe, is acute post-streptococcal glomerulonephritis, or PSGN. How does a strep throat infection end up damaging the kidneys?
It's a fascinating and unfortunate immune system overreaction. About 1 to 2 weeks after a group A strep infection, like strep throat or impetigo,
Okay.
the body produces antibodies, but instead of just targeting the bacteria, these antibody complexes get trapped in the glomeruli, or they inadvertently attack components within the glomeruli.
Triggering inflammation.
Exactly. This damages the delicate filtering membranes, making them leaky. The telltale signs are often abrupt.
Hmm.
Blood in the urine, hematuria, protein in the urine, proteinuria, swelling, edema, and sometimes dangerously high blood pressure.
That's dramatic.
It can be. But here's the surprising part. Up to half of affected children can actually be asymptomatic.
Really? Half?
Yeah. The good news is most children recover completely within about a month, with supportive care managing blood pressure, fluid balance.
That's a fascinating and somewhat deceptive immune response then. What about IgA nephropathy? I hear that's the most common globally.
Indeed it is. Immunoglobulin A, or IgA nephropathy, involves IgA protein depositing directly in the glomeruli, triggering inflammation. It's often seen in boys and frequently flares up during respiratory infections.
Causing what?
Episodes of visible blood in the urine, microscopic hematuria. Between attacks, they might just have microscopic blood or mild protein. While supportive treatment helps, a significant portion of children, maybe 20% or more, may eventually face dialysis or transplantation.
So it can be progressive.
It can be, unfortunately. It really highlights the insidious nature of some of these immune conditions. And sometimes it's part of a systemic thing, like Henoch-Schönlein purpuritis.
Okay. Next, let's focus on a distinctive constellation of symptoms. Severe protein loss in the urine, low blood albumin, high blood fats, and widespread edema. This defines nephrotic syndrome.
Yes.
A condition more common in children, often peaking between ages 2 and 3.
You've perfectly captured the key signs. And what's truly deceptive about nephrotic syndrome is how it often manifests. Imagine a child who looks incredibly swollen, puffy eyelids, especially in the morning, a distended abdomen from ascites, swollen legs.
Right.
But they're actually losing massive amounts of protein, primarily albumin, in their urine, and can become quite malnourished and susceptible to infection.
So what's causing that leakiness?
Well, the most common type in children, minimal change nephropathy, is where the kidney's filtering cells, the podocytes, undergo subtle changes. Under an electron microscope, you see their tiny foot processes sort of fuse together.
Ah.
This makes the filters incredibly leaky, specifically to albumin. The resulting low albumin in the blood, combined with sodium retention by the kidneys, causes that dramatic fluid shift into the tissues, the edema.
And the consequences?
Well, besides the swelling, children become highly susceptible to infections, like pneumonia or peritonitis. They can be irritable, fatigued. You might see diminished frothy urine from the protein, or even respiratory difficulty from the abdominal fluid buildup.
Are there other types?
Yes, there's focal segmental glomerulosclerosis, FSGS, which involves scarring in parts of the glomeruli and often has a worse prognosis. And in rare, severe cases like congenital nephrotic syndrome, the Finnish type, it's present from birth due to a specific gene mutation and doesn't respond well to standard steroid treatments.
Steroids are the usual treatment.
For minimal change, yes. Glucocorticosteroids like prednisone are the mainstay, along with managing diet and fluid. But for resistant forms, or FSGS, stronger immunosuppressants might be needed.
That's a critical point for parents and clinicians, not to be fooled by the external appearance of swelling. Now, for an acute and very dangerous condition, hemolytic uremic syndrome, or HUS, this is a truly scary trio. Hemolytic anemia, low platelets, and acute renal failure. And it's the most common cause of acute kidney failure in children under 4.
It is, and what's truly alarming about HECOS isn't just the dangerous trio, but how incredibly quickly it can cascade.
How does it start?
Most cases, what we call D plus HUS, are triggered by Shiga toxin-producing E. coli, often from contaminated food like undercooked meat or contaminated water.
E. coli.
Yeah. The toxins are absorbed from the gut. They actually bind to white blood cells, travel to the kidneys, and essentially shred the delicate filtering membranes, the endothelium, in the glomeruli.
Shred them.
Yeah, causing damage. This triggers widespread clotting within the tiny kidney blood vessels. This consumes platelets, leading to thrombocytopenia.
The low platelet.
Exactly. And red blood cells get physically damaged and destroyed as they try to squeeze through these narrowed, clotted vessels, causing the hemolytic anemia.
And the kidney failure.
The clotting blocks blood flow within the kidney, leading to acute renal failure or insufficiency.
So it's a severe rapid-fire breakdown. What does that look like in a child? What are the symptoms?
It often starts innocently enough, maybe with a GI illness, diarrhea, sometimes bloody, maybe vomiting, or occasionally an upper respiratory infection. Then, after a short symptom-free period, maybe a day or two, there's a sudden, terrifying onset of pallor, bruising, or petechia from the low platelets, extreme irritability, and a dramatic drop in urine output, oliguria.
That sounds terrifying for a parent.
Absolutely. They might also have fever, severe abdominal pain, maybe jaundice, signs of fluid overload. Sometimes the central nervous system is affected, leading to seizures. The kidney failure can set in very quickly, leading to dangerous fluid buildup, high blood pressure, metabolic acidosis, high potassium.
How is it treated?
It's mainly supportive care, managing fluids, electrolytes, blood pressure, sometimes blood transfusions. Dialysis is often needed for the renal failure. And newer treatments that target the complement system, like equidunim, are proving effective for some types, especially atypical HUS.
And the outcome?
While most children do recover with supportive care, it's a race against time. And even with recovery, there are significant long-term risks of chronic kidney disease, hypertension, even end-stage renal disease later on, plus non-renal issues.
Okay. Let's transition now to a specific but significant childhood malignancy. Nephroblastoma, also known as Wilms tumor.
Wilms tumor, right?
It's the most common kidney tumor in children, typically diagnosed before age 5.
Yes, it's an embryonal tumor, meaning it arises from immature kidney cells that didn't develop properly.
Yeah.
While it's rare overall, it's vital to recognize it in pediatrics.
Is it genetic?
It can be sporadic or inherited. It's linked to mutations in specific tumor suppressor genes like WT1 and WT2, which normally play a crucial role in kidney development.
And it shows up with other issues sometimes.
Interestingly, yes. It often appears alongside other congenital anomalies. Things like aniridia, which is a lack of the iris in the eye, or hemihyperplasia, where one side of the body grows larger than the other, and various genitourinary malformations.
How is it usually found?
Most commonly, a parent discovers an enlarging asymptomatic abdominal mass while bathing their child or dressing them.
Asymptomatic.
Often, yes. What's unsettling is that the child frequently appears otherwise healthy and thriving. Other signs can occur, like vague abdominal pain, blood in the urine, maybe anemia or fever. Sometimes hypertension happens if the tumor secretes excess renin.
What does the mass feel like?
Typically, it's a solitary, firm, non-tender, smooth mass, usually confined to one side of the abdomen. It often has a fibrous capsule around it. Bilateral tumors are very rare.
So early detection, often by a watchful parent, sounds key. What's the prognosis?
Diagnosis involves surgical biopsy or removal, plus imaging like CT or MRI to check for spread, often to lymph nodes, lungs, liver. Staging is crucial, using the National Wilms Tumor Study Group system.
What does staging involve?
Stage 1 is limited to the kidney and completely removed. Stage 2 extends just beyond but is still fully removed. Stage 3 means there's residual tumor left in the abdomen. Stage 4 means metastases to distant sites like the lungs. And Stage V is bilateral disease.
And treatment depends on stage.
Exactly. Treatment is primarily surgical removal, usually combined with chemotherapy. Radiation might be used for higher stages or metastases. The prognosis is actually quite good overall.
Really? That's good news.
Yes, high survival rates, often over 90% for localized disease, and still over 70% for higher stages. However, survivors need long-term monitoring due to increased risks of secondary cancers, heart failure, renal failure, and hypertension later in life from the treatment itself.
Okay. Important follow-up needed. Now, let's talk about some of the most common issues parents encounter in childhood related to the urinary tract. Maybe starting with the ubiquitous urinary tract infection, UTI.
Right, UTIs. Incredibly common, usually caused by bacteria, most often E. coli, ascending the urethra into the bladder.
Who's most at risk?
Certain groups are more susceptible. Newborns, especially with congenital renal abnormalities, and maybe uncircumcised infant boys. Then there's a peak in girls between 7 and 11 years old, and also sexually active female adolescents because of perineal bacteria proximity. But crucially, any abnormality in the urinary tract reflux, obstruction, incomplete emptying, stones dramatically increases the risk because urine stasis allows bacteria to multiply.
So a bladder infection is cystitis.
Yes, cystitis is inflammation of the bladder mucosa. It causes that detrusor muscle hyperactivity, leading to urgency, frequency, sometimes pain, and decreased bladder capacity. It can even cause transient reflux of infected urine up the ureters.
Leading to kidney infection.
Potentially, yes. That's pyelonephritis, a kidney infection, which is more serious.
And what would a UTI look like in a child? It can be tricky to spot, right?
Very tricky, especially in infants and young children. They might just have a fever with no obvious source, be lethargic, irritable, have feeding problems, vomiting, diarrhea, maybe even unexplained jaundice in newborns.
Not the classic symptoms, then.
Not always. Older children might show more classic symptoms like painful urination, dysuria, frequency, urgency, or maybe a new onset of bedwetting or daytime incontinence. Flank or back pain suggests the kidney might be involved.
And pyelonephritis.
Acute pyelonephritis often brings chills, high fever, and definite flank or abdominal pain. The kidneys might even feel enlarged and tender. Chronic pyelonephritis, though, can sometimes be sneakily asymptomatic.
How do you confirm it?
A urine culture is the definitive diagnosis. Dipsticks can help screen. If infection is confirmed, especially if it's recurrent or involves fever suggesting pyelonephritis, imaging, like an ultrasound or maybe avoiding cystogram, is often done to look for underlying abnormalities.
And treatment.
Antibiotics are key, usually 3 to 5 days for uncomplicated cystitis, but longer courses are needed for pyelonephritis or recurrent infections.
And the long-term impact.
The real takeaway here is the potential long-term morbidity. Untreated or recurrent UTIs, especially febrile ones in infants and young children, can lead to kidney scarring, which can cause hypertension and reduced kidney function years later.
So prompt treatment is vital.
Absolutely. And investigating for underlying issues like VUR or obstruction is crucial after significant UTI. There's some debate about long-term low-dose antibiotics, but it's considered for specific high-risk groups.
And one of those underlying abnormalities you just mentioned is vesicoritral reflux, or VUR. This is where urine flows backward from the bladder up into the ureters or even the kidneys.
Exactly.
It sounds like a big deal because it's basically a direct highway for bacteria from the bladder to reach the kidneys.
Precisely. Normally, as the bladder fills, the way the ureter tunnels through the bladder wall creates a sort of flat valve mechanism that compresses the ureter and prevents backflow.
Okay.
But in primary VUR, there's often a congenital issue. The submucosal tunnel is too short or the opening is positioned abnormally. So when bladder pressure rises during voiding, urine sweeps back up into the ureter.
And that causes problems.
It perpetuates infection. This backward flow, especially combined with a lower UTI, is a major risk factor for pyelonephritis. And repeated kidney infections, as we said, can cause renal scarring, leading to hypertension and potentially chronic kidney disease years down the line.
Is it common?
It's often undiagnosed, but studies show 30–40% of children under 5 who present with a UTI actually have VUR. It's more common in girls, less common in African Americans.
Yeah.
And there's a strong familial link.
Familial.
Yes. Siblings of a child with VUR have maybe a 27–51% chance of having it too, and children of affected parents have an even higher chance, around 70%.
Wow. So understanding its severity sounds crucial for treatment.
Yes. We grade VUR using an international system, grades WAR through V.
Can you describe those?
Sure. Grade 1 is just reflux into the ureter, no dilation. Grade 2 reaches the kidney's collecting system, still no dilation. Grade 3 shows some dilation of the ureter or blunting of the calyces in the kidney.
Okay.
Grade 4 shows gross dilation of the ureter and calyces. And grade 3, there's massive reflux with a very dilated, tortuous ureter and loss of the fine details in the kidney's collecting system.
And the grade matters.
Definitely. It directly influences management and prognosis.
Oh.
Lower grades, especially IN2, have a high chance of resolving spontaneously as the child grows, maybe 50–80% in kids. Higher grades, IVNV, are less likely to resolve on their own, maybe only 20%.
How does it present clinically?
It could be asymptomatic, just discovered during an evaluation for a UTI, or it might present with recurrent UTIs, unexplained fevers, poor growth, irritability, feeding problems, or if there's a family history.
How is it diagnosed?
The main test is avoiding cystoethrogram, or VCUG. That's where contrast is put into the bladder and x-rays are taken while the child urinates to see if reflux occurs.
And treatment.
Prompt UTI treatment is paramount. For the VUR itself, management ranges from watchful waiting with or without prophylactic antibiotics for lower grades to surgical correction for higher grades, or if there are breakthrough infections or worsening kidney function.
Okay. Finally, let's address an issue many families grapple with. Urinary incontinence. That's the involuntary passage of urine by a child past the age when bladder control should normally be acquired, usually around age 5.
Right.
We often differentiate daytime accidents from nighttime wetting, which is called enuresis. And sometimes there's no clear physical cause found functional incontinence.
Yes, it's a very common concern. Enuresis affects up to 10% of 7-year-old boys, though it tends to resolve spontaneously over time. Daytime incontinence occurs in maybe up to 9% of early school-age children.
What causes it? Seems complex.
It is. It's often multifactorial. We always need to rule out organic causes first, even though they account for a minority of cases.
Like what?
Things like UTIs, underlying neurological problems, congenital defects of the urinary tract, even allergies, or disorders that increase urine output like diabetes mellitus or diabetes insipidus, or things that impair the kidney's ability to concentrate urine, like chronic renal failure or sickle cell disease. But it's also frequently associated with other things. Constipation is a big one.
Yeah.
Also ADHD, developmental delay, altered sleep arousal patterns, or obstructive sleep apnea for nighttime wetting.
And psychological factors.
Yes, psychological stress, like the arrival of a new sibling or starting school, can certainly trigger secondary incontinence, where a child who was previously dry starts wetting again. And there's definitely a genetic component for some types, especially in ureteropelvic.
So it's really not just a behavioral issue then, usually.
Absolutely not. It's rarely just willful misbehavior. We need to distinguish primary incontinence, where the child has never been consistently dry, from secondary incontinence. And there are various patterns: urgency incontinence, stress incontinence, dysfunctional voiding patterns, overactive bladder, underactive bladder.
How do you approach figuring it out?
Evaluation is comprehensive. It starts with detailed questionnaires, maybe having the family keep drinking and voiding diaries. A thorough physical exam is crucial, looking for neurological signs or physical abnormalities. Urinalysis is essential to rule out infection or other underlying pathology.
And sometimes more tests.
Sometimes, depending on the history and findings, radiologic studies like ultrasound or even urodynamic studies, which measure bladder pressures and function, might be needed.
What about management?
Management really centers on educating the child and the family, reducing any blame or shame. For daytime issues, behavioral therapy is often key things like timed voiding schedules, ensuring adequate fluid intake, but maybe managing timing, and aggressively treating any constipation or UTIs. Sometimes medications like anticholinergics or alpha blockers can help specific bladder issues.
And for nighttime wetting, enuresis.
Besides behavioral strategies, enuresis alarms, which wake the child at the first sign of wetness, can be very effective over time by conditioning bladder awareness during sleep. Medications like desmopressin are sometimes used too. The key is a patient, supportive, and holistic approach, recognizing the underlying complexities.
So what does this all mean? We've covered an incredible amount of ground today.
We certainly have.
From those tiny developmental glitches leading to major structural abnormalities like, hypoplastic kidneys or hypospadias, to the immune system's impact on the delicate glomeruli in conditions like nephrotic syndrome and HUS, and even the complexities of common things like UTIs and incontinence. Our deep dive has really illuminated that congenital anomalies are a widespread and major cause of renal failure in children. It highlights the unique vulnerabilities of these developing bodies.
That's a key takeaway.
We've seen how immune-mediated glomerular disorders, from acute post-strep issues to chronic conditions like IgA nephropathy, can stealthily compromise kidney function over time.
Right. The immune system plays such a huge role.
We also discuss nephroblastoma, Wilms tumor, a significant but importantly largely treatable childhood kidney cancer.
Good outcomes there, mostly.
And finally, common bladder disorders like UTIs and VUR really underscore how crucial early diagnosis and treatment are to prevent that long-term kidney damage. And urinary incontinence reminds us of the many subtle interacting factors that influence bladder control in children.
It's a complex interplay.
This journey truly emphasizes the intricate balance of pediatric renal health.
It does, and it really raises a fascinating, maybe broader question. How might a deeper understanding of these specific pediatric vulnerabilities, the developmental aspects, the immune responses, influence how we think about promoting kidney health throughout an entire lifetime, starting right from birth or even before? How can we better screen and intervene early?
That's a great thought to leave our listeners with. Thank you for joining us on this deep dive. We hope this has provided you with a clear, valuable shortcut to being well-informed on this important topic. This has been a Last Minute Lectures deep dive.